Hi, Dr. Patricia A. I'm one of the hematologist-oncologists, and we're going to talk today about iron deficiency anemia in the setting of chronic kidney disease. So anemia is really common in chronic kidney disease and actually can have a lot of adverse effects, which we'll talk about on mortality, on cardiac function, and of course, quality of life. About 44% of our patients are anemic with chronic kidney disease stage 3 or 4, while as that progresses, upwards to 75% will have anemia in stage 5. So what are the causes of anemia with chronic kidney disease? Certainly with a failing kidney, it's low production of erythropoietin. Second, though, is iron deficiency, and that can be either functional from all the inflammation that's caused, leading to a decreased absorption of the iron pills or the iron we're eating in our food. And also there's decreased mobilization of our storage iron to the erythroid progenitor cells. So that's functional iron deficiency. But we can also have absolute iron deficiency, which means low iron stores from poor nutrition, maybe occult GI bleeding in this patient population, and frequent phlebotomies can lead to iatrogenic blood loss. So let's talk a little bit about how we want to screen our patients. Anybody who's anemic, we want to screen them with iron studies, but don't forget other reasons. So you also want to look for other nutritional deficiencies such as B12 and folate, and make sure that you're doing hemoccult testing, that there's no occult GI bleeding. So why do we want to treat them? So we want to treat anemia because it leads to better quality of life, more energy, less fatigue. And also studies have shown that it impairs cardiac function with chronic anemia, leading to left ventricular hypertrophy, which can increase mortality and cardiac complications. Also, anemia has been found to be an independent predictor for increased mortality in this chronic kidney disease population. So what are our treatment options for anemia? There is transfusion as a last resort, but remember that's very temporary and carries a lot of risk. So preferred is to give them erythropoietin or erythropoietic stimulating agents and iron. Now, when do we add iron? So iron can be very beneficial to decrease the amount of erythropoietin that's needed and also to restore iron. So when you're doing your iron test, which is basically ferritin and TSAT, we know that if the TSAT is under 20 and the ferritin is under 100, that patient has iron deficiency and should receive parenteral iron. Remember, oral iron is going to be ineffective because you're just not going to absorb it. And then we know even if the TSAT is 20 to 30 and ferritin is 100 to 500, you may still have iron deficiency, and these patients may benefit from parenteral iron. Once the TSAT is over 30 and the iron ferritin level is over 500, there's no value to give an IV iron in that population. So again, we want to give iron to increase hemoglobin response, which will also lead to improved cardiac function, quality of life, and then we'll decrease our transfusion requirements and also decrease the amount of erythropoietic stimulating agents that might be required. So in summary, anemia is common in chronic kidney disease and can be easily treated with intravenous iron, which will allow us to avoid transfusions and will also facilitate the response to the erythropoietic agents.